Hi, everybody. Thank you so much for coming today and coming out in this very, very cold weather. We appreciate it. I hope you didn't all freeze like I did. I'm here to talk about the Centers for Medicare and Medicaid Innovation. I know you've all heard a lot about this. I personally really love this graphic. I think it really says it all about healthcare reform and CMMI. Tracy did a really nice job of summarizing all the problems with our healthcare delivery system. I think that this slide really says, yep, we recognize it, the legislature recognizes it, Congress recognizes it, what are we going to do about it? Congress doesn't know. So they punted. They punted to CMS and they punted to CMMI, and they're really hoping that we can implement delivery system and payment system changes over the next 9 years that will both increase efficiency, reduce costs, and increase quality. Notably, CMMI was one of the very first healthcare reform measures instituted by CMS. It was mandated to be created in January of 2011, just this month. They beat the timeline, and it became effective and was established in November of 2010. What it's charged with is testing payment and service delivery models designed to reduce Medicare and Medicaid spending while preserving or enhancing quality of care. Essentially, in the words of Rhea Cohen, CMMI is going to let 10,000 flowers grow and see what happens. However, in order to test these and implement such sweeping changes, Congress recognized that CMMI is going to have to be a little more nimble and have more authority than CMS has typically had in the past. So many of you may be thinking what I was thinking when I first heard about CMMI. What is the difference between this and demonstration projects that we've seen in the past? We at Reinhardt have done demonstration projects. We've been successful with demonstration projects, and I think that we've seen what Congress really saw when they were putting together CMMI. It's a slow process, and it's expensive for providers, and you lack some incentives to go down this path if you know that you're going to have to put the capital into it. So there are a couple of things that are different about CMMI than what we've seen in the past with demonstration projects. CMMI is not going to have the kind of luxury of the kind of time that we've seen in the past. So the Secretary of HHS is going to have broad authority to expand any program that they think is successful. This is really important because in the past, reform efforts, or as Congress saw it, or really I guess as CMS saw it, reform efforts have been held back because waiting for congressional approval. Either they waited to implement them. I know that there was a demonstration project that tested competitive bidding for DME in 1999 to 2000. It was successful. It reduced Medicare spending by 19%, and Congress looked at it and waited to implement it until 2010. So the broad authority afforded to the Secretary of HHS probably should ameliorate that problem or reduce that concern. The second thing that I think is the most valuable and really the most interesting about CMMI is that they've received $10 billion in funding. CMS has become a venture capitalist firm. They're going to be looking for things that they can invest in, and they're going to give health systems and people who are innovative the capital to go forward with projects that are going to bring them a return. I think that's a new role for CMS. Typically, they've asked things to be budget neutral. They haven't been willing to invest in the future. In this case, they are. So there's a lot of money here that's going to be available to health systems who are willing to take the leap and be innovative and think outside the box. One of the things that CMMI has done over the last couple of months is appoint an acting director and a deputy director. And the reason that I have a whole slide dedicated to these two individuals is because I think their backgrounds are important. And I think that they say a lot about where CMMI is going, what they think that what the important points and where they want to focus their attention. First of all, Julie Bond was the former Chief Information Officer of CMS. I think information technology is going to be very important to CMMI, and we'll explain that in a little more detail a little later. More importantly, Dr. Gilfillan is a payment expert. Prior to being named as CMMI's acting director, he served as the director of performance-based payment policy at CMS. Prior to that, he worked at Geisinger. He was the president and CEO of Geisinger's health plan and the executive vice president of insurance operations for the health system. At Geisinger, he helped develop bundled payment, episode of care, and something called proven care. Don Berwick referred to proven care as probably the most important achievement in the country with respect to the reliability of health care, producing better results for patients with highly reliable processes of very complex forms of care. For those of you who don't know what proven care is, it was launched by Geisinger in 2006. It was an experiment that they included 3 key features. The first was a strict reliance on evidence-based standards of medicine. The second was a fixed price, financial mechanism to pay for certain procedures. And the third was patient engagement and activation. So what does that mean? Basically, they started with elective coronary bypass surgery. They went to their health plan, which makes it easier, went to their health plan and said, give me a flat rate for surgery, give me a flat rate for what has historically been paid for post-op care. We will take the risk that it's going to work, and we will care for these patients 90 days afterwards on our own dime. Some have referred to proven care as surgery with a warranty. If a patient experiences avoidable complication within 90 days, Geisinger is going to cover it. With respect to the evidence-based medicine, they worked together with their doctors. They created 40 essential steps and then devised procedures to ensure that each of those steps would be followed. And then, of course, there's that essential step of patient interaction. They had to follow up with their patients. They had to ensure that they were taking care of themselves and doing what they needed to do to make sure that they were healthy and they weren't going to be readmitted to the hospital. The results were pretty staggering. Death rates down, readmission rates within 30 days down, lengths of stay down, hospital charges down, costs down. And Geisinger was able to keep, the health system was able to keep all the benefits from what they saved by not having to do extensive post-op care. They've expanded the program. They have 7 other procedures, hip replacement and cataract surgeries being 2 of them, and they want to market this to other insurance companies. So CMMI has this goal. They're going to have to move quickly. They want to invest. They're going to, in large part, they have been tasked with reforming the payment and delivery systems and really implementing the healthcare reform on the ground. So how are they going to do it? Some of the greatest minds think that this is the way that CMMI is going to look. We are still waiting to see what they're going to do. A lot of the details haven't been worked out, but this is what we're sort of looking with. We're looking at standard templates for evaluating payment reform. Everyone's going to go through the same application process. Everyone's going to have the same standards, regardless of what your project looks like. You want to design with the end in mind. How are they going to expand these projects? How are they going to get that return on their investment? They've invested with you. How can they make money somewhere else? A common set of metrics. They're going to evaluate every project the same way. Cost and quality, they want to know how you compare apples to apples with somebody else doing something different. Innovation through performance standards rather than design measures. Timely, relevant data exchange for continuous real-time evaluation. This is important because in the past, with demonstration projects, it's taken about 5 years to really evaluate how projects are doing. And CMMI, as we've said, and I keep reiterating, doesn't have that kind of time. So they recognize that they're going to have to look at claims data for the time being. But really, they're going to try to move forward and do real-time continuous evaluation. And then they want to leverage models with demonstrated proof of concept. Yeah.
I understand cutting costs is one of the primary goals of CMMI.
Yes.
And they also want proposals to be submitted for disseminating $10 billion that they've been assigned.
Yes.
Have they identified the challenges and opportunities as a whole in the system so we can respond to those challenges and problems?
You know, they have. They've been talking in general terms. Really what CMMI has been doing over the last few months that they've been here, they've been listening. They want to build off of what other people are doing. They want to leverage other models. 2 that came to mind and 2 that keep popping up were the Blue Cross Blue Shield of Massachusetts is paying, they've implemented contracts covering 20% of their participating providers. They want to latch on to these types of ideas where they're just paying quality-based bundled payments for services. I know it's an idea like proven care. They want to latch on to that idea. How can they make that work? How can they move it outward? But really, the innovation isn't going to come from CMMI. It's going to come from us. It's going to come from you. It's going to come from your boards, your workers, people who know the system, understand it from the ground up, and how can we make this system better together? But they are going to give performance standards. What they're going to tell you is, we want to cut costs. We want to increase quality, or at least keep it the same. How can we do it? Why should we invest in you? And how can we make money going forward? I just wanted to come back to this idea of designing with the end in mind. I don't think that this can be understated. I think that this is really, this is where we really stand. We really want to focus on design. We know they want to cut costs. We're pitching to the government. We want their money. We have ideas. How can we deliver care better, cheaply, that it won't break our backs, but that they can make money in the future? We have, at Reinhardt, have been working with a number of different people. We've been contacting WHA. We've been in contact with Chris Coram at the Wisconsin Collaborative for Healthcare Quality. John Foley's here, Keith Kiefer's here, actuaries, insurers. I think that this is really a collaborative process. We can learn as much as humanly possible about how we can do this better and make money doing it. I just wanted to wrap up to talk about their current innovation projects. They've announced 4 innovation projects that they're currently working on. The reason that I think that this piece is important, and it's going to be very relevant to you, it's very important to keep an eye on what they're doing, what's successful, what's working, what's not working. And the reason is because you might see these come out in regulations in a year, 6 months, they're going to move fast. So it's good to stay in the front end, see what CMMI is doing, see how it might impact your business. The first, this multi-payer advanced primary care practice demonstration. 8 states will participate in multi-payer advanced primary care demonstration projects. It's going to include medical homes serving 1 million Medicare beneficiaries. They're going to evaluate the effectiveness of doctors working in a more integrated fashion, receiving more coordinated payments. The second is this federally qualified health center advanced primary care practice demonstration. The federally qualified project will test the effectiveness of doctors and healthcare professionals working in teams to treat low-income patients at community health centers. A new state option, this home health initiative, is going to let Medicaid patients pick a physician to function as their home health, coordinating treatments with other professionals. And then the dual eligible beneficiaries. State programs are going to get up to $1 million each to develop programs. They're going to showcase the benefits and savings of dual eligibles. They want to know what they're paying more for that they can pay less for. Does anyone have any questions? I went through it quickly. Okay. I'm going to give it back to Tracy.